My name is Arishenkoff. I am a member of the UBC-IM PoCUS team. Identifying the height of the JVP is a fundamental clinical exam skill. Like many PoCUS applications, I have found that turning the probe on the JVP has led me to find a new appreciation for the usefulness and complexities of this exam. In this video, I will review the ways that ultrasound can be used to estimate CVP on the basis of examining the internal jugular vein. I'll also spend time reviewing the anatomy and nuances of the appearance of the IJ using ultrasound. I have found that, as with most ultrasound applications, there is an obligation to provide the necessary background in order to help the learner avoid misinterpretation and clinical errors. The objectives of this presentation are to review the anatomy and physiology of the internal jugular vein. As mentioned, there is a certain amount of background information that is needed in order to understand the appearance of the IJ on ultrasound. Next, I will discuss image acquisition and review the setup of the exam and look at different factors related to the appearance of the IJ that can inform the clinician about CVP. Along the way, I will also make note of important features of the exam that can impact interpretation and clinical integration. Just a quick note about the IVC. In general, I look at both. They should corroborate one another. If they are grossly different, one of them is tricking you, and you need to figure out why. If one is in the gray zone, in other words, you cannot be confident about the interpretation, the other may be more helpful. Please see the companion IVC screencast on the UBC-IM PoCUS website. The IVC screencast incorporates a discussion about the relationship between CVP and volume, as well as clinical integration. Anatomy and physiology of the internal jugular vein. We don't need to go into great depth, but there are a few aspects of the internal jugular vein anatomy that I want to draw your attention to. These points will factor into our discussion about how the appearance of the IJ relates to CVP. First, the IJ is one of the main channels for venous drainage of the head and neck. It can be seen here. It receives runoff from the sigmoid sinus in the brain and combines with the subclavian vein, seen here, to form the brachiocephalic vein at the level of the clavicle, seen here. Second, there is a valve just before the IJ combines with the subclavian. This is approximately 0.5 centimeters from the subclavian. Third, the potential internal diameter of the IJ is much greater than the common carotid artery. The common carotid artery is generally 6 to 7 millimeters, whereas the IJ is generally 14 to 19 millimeters. However, significant size variation has been reported, with one study showing that 3 out of 93 IJ diameters were less than or equal to 6 millimeters. Finally, the diameter narrows as the IJ approaches the angle of the jaw. As such, you can expect to see a natural tapering of the IJ as you follow it from the clavicle to the angle of the jaw. As mentioned, the internal jugular vein is generally considerably larger than the common carotid artery. However, there is variability, and on occasion the IJ may be small. There may even be variation from left to right in the same patient. These images are taken from the right and left internal jugular veins of the same patient. I did confirm that the right internal jugular vein was compressible. It can be seen here, circled in red. It's always good then to compare that to the size of the common carotid artery, which is situated right here. When we went to the left side, you can see here that the internal jugular vein is actually quite a bit bigger than the common carotid artery on that same side. This may be congenital or a secondary phenomenon such as a damaged vessel related to multiple CVC cannulations. When reviewing the JVP, another important anatomical consideration is the relationship of the internal jugular vein and the right atrium. As we all know, the height of the JVP is based on the height of the column of blood above the right atrium. Because we cannot visualize the right atrium, the convention is to use the sternal angle as a reference point. It has been widely accepted that the sternal angle is approximately 5 centimeters above the right atrium. However, in general, it is inaccurate and often leads to significant underestimation of CVP. In this study, investigators used CT scans to calculate the distance between the right atrium and sternal angle, and not only found that there was a significant variability in the distance, but also that the distance increased with a steeper incline of the head of the bed. It is notable that these numbers are well above 5 centimeters. As we will discuss, the PoCUS evaluation of the JVP includes identifying the position of maximal collapse of the internal jugular vein. Understanding the relationship between changes in the internal jugular venous flow and patient position described in this figure is helpful when assessing jugular venous distension and collapse. This diagram illustrates the difference between flow through the IJ when the patient moves from a supine position, shown here on the left, to an upright position over here on the right. In the supine position, the jugular veins are the primary venous drainage for the brain, and the vein remains open. In the sitting or standing position, the internal jugular vein collapses due to effects of gravity as blood flows into the right heart. Collapse of the internal jugular increases resistance to flow. When this happens, the vertebral venous plexus becomes the major exit pathway from the brain. Under normal circumstances, when the CVP is not elevated, the column is not seen above the clavicle in the upright position. It would look something like this. As right atrial pressure increases, the internal jugular vein remains open due to the extension of the column from the right heart cranially, and the vessel remains open. Further to the study discussed on the previous slide, the investigators in this study documented the size, area, and flow through the IJ in the supine position versus the standing position. The subjects were 25 young, healthy volunteers. Presumably they had normal CVPs. This clearly shows the considerable difference between the IJ size when supine versus standing when the CVP is not elevated. We can see here in the supine position, it was around 0.42 centimeters squared. However, when standing, much smaller at 0.07 centimeters squared. These numbers help us understand what we should expect in patients with CVPs that are not elevated. It is notable that, even in individuals with normal CVPs, we should not expect the IJ to be fully collapsed when the head of the bed is not elevated. However, considering that the potential diameter of the IJ is 14 to 19 millimeters, an IJ area of 0.42 centimeters squared is certainly not distended. In other words, the venous walls are not dilated or under pressure. I believe that recognizing the positional variability and flow through the internal jugular vein will help us make sense of the IJ images we will encounter clinically. It is crucial that the clinician is able to differentiate between layering and jugular venous distension. For now, the message is, when supine, the IJ often remains open regardless of right atrial pressure. However, it is not distended. The volume within the IJ is layering out. This is due to the increased return from the brain and less effect of gravity on the column. In those with an elevated right atrial pressure, the IJ is distended. As mentioned, in general, an IJ diameter is 14 to 19 millimeters. When under pressure, the IJ becomes more circular in form and larger in diameter. In addition, the column extends up the neck even in the upright position, despite the fact that venous return from the brain is decreasing. One final point about internal jugular vein anatomy that can significantly impact how we interpret the JVP. When the probe is placed just above the clavicle, the portion of the internal jugular just before it joins with the subclavian vein and brachiocephalic vein is generally visible. This is seen right about here. This location is in the vicinity of the internal jugular vein valve and the intrathoracic portion of the vein, which is probably in this region here. It is notable that the IJ may be splinted open by the negative intrathoracic pressure, valve, and intersection of the internal jugular, the subclavian, and the brachiocephalic vessels at this location. Because of this, an IJ may seem to taper just above the clavicle in the same patient lying at 10 degrees or 60 degrees. This could be interpreted as an elevated CVP at 60 degrees and a normal CVP at 10 degrees. Therefore, we need to exercise caution assigning the height of the JVP with the probe at the level of the clavicle, as the IJ can be seen to distend at this level independent of CVP. One author suggested adjusting the bed until the taper is in the middle third of the neck to be sure. So, if the height of the JVP appears to be at the level of the clavicle when the patient is at 60 degrees, lower the head of the bed to see if you can relocate the IJ to the middle third of the neck. If the maximal collapse does not shift, the location of the JVP at 60 degrees was likely artifact. With this background of anatomy and physiology in mind, let's move on to image acquisition and interpretation. Before beginning the exam, here are a few key points to think about to maximize your chances for success. First, take a moment to optimize your setup. The linear array transducer, a high-frequency probe, is ideal for superficial structures such as the internal jugular vein. Most machines should have a vascular or venous preset. Consider any history of trauma, surgery, or central venous catheter cannulation that might make the right or left IJ preferable. Next, in general, structure should be interrogated in two views. Because the IJ is often tortuous, the short axis is by far the most important of the views when assessing the height of the JVP. Next, utilize internal and external landmarks to help you identify the IJ efficiently and accurately. Next, take note of the patient's breathing effort. This can significantly impact the form of the IJ. Finally, do not rely heavily on a single data point. The assessment of the IJ must be carefully integrated into the rest of the clinical exam, including other PoCUS information. A quick note about patient position. The internal jugular vein cannot be properly interrogated in a patient that has migrated to the foot of the bed, as seen in the image on the left. The IJ serves as a manometer. There must be free flow of fluid within the manometer. Therefore, the head, neck, and upper body must be in a neutral position. In other words, the patient should not turn their head and should be lying on their back with their backside snugly fixed to the angle of the bed. In general, this means that patients will often need to be hoisted up the bed before scanning the JVP. I will often take my first look with the head of the bed flat, for reasons that I will get into in a moment. Although if I'm expecting a grossly elevated JVP, I will usually begin with someone in a more upright position. We should use whichever side of the neck that is going to give us the best information. Out of habit, I generally start with the right side of the neck, although there is nothing to say that the left is less accurate. There may be a clear reason to start with one side of the neck, as listed here. However, if you encounter something unusual about the image on one side of the neck that may impact your interpretation, it is a good habit to take a look at the other side as well. External landmarks should be used to guide the initial placement of the transducer. When scanning the internal jugular vein, place the transducer across the two heads of the right sternocleidomastoid in the transverse plane with the probe marker oriented towards the patient's right. In this orientation, the IJ generally lies just lateral and superficial to the aorta. It is important to be able to recognize some of the surrounding sonoanatomy, in particular identifying an internal landmark that can help you identify the object of interest efficiently and accurately. The internal landmark should be a structure that is consistently easy to find, even when the object of interest isn't. In the case of the internal jugular vein, the carotid artery is a useful internal landmark. When we look at the image here on the left, we can see that the probe is on the right aspect of the neck. The lateral aspect of the neck is over here, and the medial aspect of the neck is over here. This is the common carotid artery. Just superficial and lateral to the common carotid artery is the internal jugular vein. Just superficial to that is the sternocleidomastoid. Notice the hypoechoic appearance of the sternocleidomastoid with the hyperechoic fibrils that are running obliquely through it. Another muscle over here, just lateral and deep to the internal jugular vein, is the anterior scalene. Finally, on the medial aspect of the neck, we see the thyroid. Note the uniform echotexture associated with this endocrine organ. Finally, although not easily resolvable here, the vagus and phrenic nerves sit just deep to the IJ and the carotid. From here, we will review a few PoCUS features of the internal jugular vein that correlate with central venous pressure. First, we will discuss the internal jugular vein size relative to the carotid artery. As mentioned, the size of the internal jugular vein is greater than the carotid artery. The image on the left shows a distended jugular vein that is much larger than the carotid artery. Here is the carotid artery. It is dwarfed by this very large internal jugular vein. Next, look at the IJ form. Is it circular versus ovoid? An internal jugular vein that is distended will take on a more circular form. The image in the middle shows an IJ that is relatively empty with an ovoid rather than circular form. Here is the internal jugular vein right next to a circular common carotid artery. Next, we will look at the location of maximal tenting as a way to identify the height of the JVP. The image on the right is a long axis view of the internal jugular vein that shows the location where the internal jugular vein is tenting. This location corresponds to the position of the neck where the jugular venous pulsation can be seen on physical exam. Right here is that location where you can see the tenting of the internal jugular vein. In order to find the point of maximal tenting, the internal jugular vein must be imaged along the length of the neck. Although a long axis image is shown here for demonstration purposes, we will encourage you to focus more on the short axis. This is the most well-studied of the components of the internal jugular vein exam for central venous pressure. I begin my assessment with the patient in the supine position and the head of the bed relatively flat in order to assess the size and shape of the internal jugular vein. Start with the probe in the transverse plane just above the clavicle. Survey the internal jugular vein in short axis to identify the location of the widest diameter. If the central venous pressure is elevated and the patient is in the supine position, the internal jugular vein should be distended and approaching its maximum diameter. In general, a full internal jugular vein will be much larger than the common carotid artery with a diameter between 14 and 19 millimeters. In the study shown here, the investigators looked at both the widest diameter of the internal jugular vein and the internal jugular vein to common carotid artery surface area ratio. They scanned 52 patients with central venous catheters and excluded both patients on mechanical ventilation or with tracheostomies. Patients were placed in the supine and horizontal position with no pillow. Ultrasound images were obtained in the transverse plane at the lowest level of the thyroid cartilage. Measurements obtained at end inspiration and end expiration. The largest diameter and the cross-sectional area of both vessels were measured. The patients in this study had a mean CVP of 8.71 and of these, 22 had CVP greater than 10 centimeters of water. In those with a normal CVP, the IJ diameter was less than 10 millimeters. And the IJ to common carotid artery ratio was less than 1.5. In general, I am not using calipers, but just getting a rough sense of the IJ size compared to the carotid artery. If the IJ is smaller than the common carotid artery, it is very unlikely that the CVP is elevated. I also look at the form of the internal jugular vein. If the CVP is elevated and the patient is in the supine position, the internal jugular vein should be distended and take on a circular form. In other words, a venous structure that is not under pressure tends to collapse. In this study, the investigators looked at 44 spontaneously breathing critically ill patients with sepsis. Once again, the patients were positioned supine and horizontal. The transducer was placed perpendicular to the neck in the transverse plane over the expected location of the internal jugular vein. The position of the transducer was adjusted over the vein to find the most circular cross-sectional area. The height and width of the internal jugular vein were measured at end expiration. They found that the CVP was not elevated when the ratio of the short to long axis was less than 0.83. The correlation is clearly not perfect. As with each of these components, they tend to perform in a mediocre fashion as dichotomous variables. They are more powerful at extremes. The figure on the right shows that as the ratio gets below 0.6, or over here, it is very unlikely that the CVP is elevated. In addition, as the ratio approaches 1, it is very likely that the CVP is elevated. Once again, I do not tend to use calipers, but rather look for internal jugular veins that are distinctly ovoid or approaching circular to help identify those with CVPs that are not elevated or elevated, respectively. The third component of the internal jugular vein assessment for central venous pressure is looking for the point of maximal tenting. This is the sono equivalent of the jugular venous pulsation seen on traditional physical exam. The point of maximal tenting is the superior margin of the column of blood extending from the right atrium. I start with a view of the internal jugular vein in short axis with the transducer just above the level of the clavicle. Once again, compare the size of the IJ to the carotid and take note of the form. In the images shown here, the IJ is indicated by the arrow and the carotid by the red circle. The image on the left shows the same distended internal jugular vein seen on the previous slide. We are clearly below the point of tenting in this image. In order to find the location of maximal tenting, slide the transducer towards the angle of the jaw. The image in the middle is an IJ with a small ovoid appearing form, which is no bigger than that of the carotid. This may represent a region where the IJ is tenting or could just be layering of blood as it drains back to the right atrium. The distended portion of the internal jugular vein is below the level of the probe, in other words, closer to the right atrium. Lowering the head of the bed may better reveal the location of the distended portion of the IJ. The image on the right shows a collapsed IJ. This is well beyond the level of maximal tenting. The height of the JVP is below the position of the probe. Lowering the head of the bed may help reveal the column and location where there is maximal tenting. If a distended internal jugular vein is found, slowly slide the transducer up the length of the neck. tenting of the IJ will be readily seen in short axis as an acute reduction in the internal jugular vein diameter. The middle image shows an IJ that remains distended throughout the length of the neck. In other words, there is no tenting. The internal jugular diameter does decrease as the probe approaches the angle of the jaw. However, the form remains circular. Anatomically, the size of the IJ decreases as it traverses the neck towards the angle of the jaw. If this is the case, the head of the bed should be raised in order to bring the location of maximal tenting into view. If the patient is already sitting fully upright, the height of the JVP is beyond the angle of the jaw and not accessible by ultrasound. The image on the right shows a distended IJ. As the probe slides towards the angle of the jaw, the diameter of the IJ quickly diminishes with a near complete collapse. The height of the JVP is in the location on the neck that corresponds to the position of the probe on the neck where the transition occurs. Here is the IJ, and as we slide up the neck, we see that it becomes smaller and smaller until it completely collapses. Consider looking at the IJ in the long axis. However, be cautious about the interpretation, as the IJ is often tortuous, which makes it difficult to remain over the center of the vessel. The location of the JVP is along the length of the tenting of the internal jugular vein, although there is some inconsistency in the literature about the precise location. I would like to reiterate that an open column does not necessarily suggest that there is pressure extending from the right heart. These clips are from the same person with a normal right atrial pressure. The clip on the left is taken with the head of the bed at about 30-degree incline and the transducer just above the clavicle. The IJ is empty in this position, with gravity drawing the column below the level of the clavicle. The IJ can be seen here. The middle clip shows the same IJ at 0 degrees. The transducer begins at the level of the clavicle and then slides towards the angle of the jaw. There is fluid layering out in the vessel as return from the head increases and the IJ flattens out. The IJ can be seen here. However, it is clear that the size of the IJ is much less than that of the carotid, and there is no clear taper. This is layering, which is not the same as the pressure column that is related to jugular venous pressure. The third image is a long axis of the internal jugular vein in the same person at 0 degrees. In other words, the same position as the middle image. This nicely shows the layering without distension or clear tapering. Sometimes the taper can be found to be drawn out over several centimeters. In this case, it is unclear at which position along the taper the JVP is located. I'm trying to demonstrate this here with the image up top. This has been described with the traditional physical exam as well, where the JVP pulsation can be diffuse and along the entire length of the neck. In this case, increase the incline of the head of the bed. Gravity will pull the column into a shorter and more acute taper. I want to draw attention to the presence of a taper at the level of the clavicle. We must consider the impact of the anatomy of the internal jugular vein at the level of the clavicle when identifying the location of the taper. As mentioned, a combination of the negative intrathoracic pressure, confluence of the internal jugular vein with the subclavian and brachiocephalic vein, as well as the presence of the valve, tend to stent the IJ open at this location. As such, the taper of the IJ at the level of the clavicle may have nothing to do with the right atrial pressure. The image on the right was taken from a study looking at imaging the IJ taper in patients likely to have a normal jugular venous pressure. The jugular venous pressure was assessed
with the patient at 45 degrees. 96% of the patients had a taper just above the clavicle. It seemed improbable that all of the subjects would have JVPs just greater than 6 centimeters, and virtually 0 subjects had a JVP between 0 and 6 centimeters, recognizing that a normal CVP should be between 0 and 8 millimeters of mercury. I suggest that the findings in this study inadvertently illustrate the effects the anatomy can have on the taper. I wonder what may have happened had the investigators lowered the head of the bed. We suggest that if the location of maximal tenting is just above the clavicle, lower the head of the bed. If the location of maximal tenting remains just above the clavicle, the location of tenting is likely related to previously mentioned anatomic phenomenon, and the true JVP probably lies at or below the level of the clavicle. This slide illustrates the impact that forced expiration can have on the appearance of the internal jugular vein. I bring this up here because it seems to me that this variation is seen much easier using ultrasound and can frustrate interpretation. Forced expiration results in a positive intrathoracic pressure. The internal jugular vein will transiently distend. The internal jugular vein will vary widely in diameter and height throughout the respiratory cycle. Under these circumstances, it is generally recommended to look for the location of the maximal taper in early expiration. You can see here on this image that the IJ distends significantly towards end expiration. Finally, I want to review the effect that Valsalva has on the internal jugular vein and its relationship with central venous pressure. I suggest this can be a helpful part of the internal jugular vein exam, especially in those with a pronounced forced expiratory phase when the column in the IJ is fluctuating over several centimeters. This is, of course, assuming that the forced expiratory effort is approximating the effects of Valsalva. The investigators in this study scanned the IJ at admission prior to right heart cath in patients admitted with acute decompensated CHF. A ROC curve was generated to identify hypervolemia, or a CVP greater than 12 millimeters of mercury. I find this a bit curious, given this is well above what we would generally consider a normal CVP. Nevertheless, patients were positioned with the head of the bed at 45 degrees. The probe was placed in the transverse plane at the apex of the sternocleidomastoid muscle to obtain a cross-section of the internal jugular vein. Stills of the internal jugular vein were taken at end expiration during relaxed breathing, and a second set of images were obtained during the strain phase of Valsalva. A manometer was used to obtain a respiratory pressure of 40 millimeters of mercury during Valsalva. Cross-sectional area was traced for each of these images. Over here we can see that when they looked at the IJ vein area, when an increase was less than 66%, they were able to predict an elevated right atrial pressure greater than 12 millimeters of mercury with these test characteristics. This image here on the right shows a patient with normal CVP during the strain phase of Valsalva. And you can see how the internal jugular vein goes from completely collapsed to much greater than the size of the corresponding common carotid artery. Clearly here, the increase in size of the internal jugular vein is greater than 66%. I suggest that if during a strong forced expiratory effort that the size of the internal jugular vein doesn't increase by more than 2/3, the CVP is likely elevated. Let's consolidate the different components of the internal jugular vein assessment for CVP. As discussed in the UBC-IM PoCUS screencast on the IVC, the power of the exam lies at the extremes. Recognizing that some of these data points do not function well as dichotomous variables, we need to exercise caution when making conclusions about these variables on the margins of a given threshold. Differentiating a very mild increase in CVP from a high normal CVP is likely not possible. As such, the power that these findings have to impact the clinical impression about a patient's volume status or right heart function depends on the significance of the findings. Consider the diagram here. At the far left of the spectrum, findings of multiple data points all strongly indicate the CVP is not elevated. For example, the IJ is smaller than the carotid artery and ovoid in form. The location of maximal tapering is not visible above the level of the clavicle, even when the patient is horizontal, and there is greater than doubling of the size of the internal jugular vein with Valsalva. That can be seen on this side. To the far right of the spectrum, over here, the data points would all strongly indicate an elevated CVP. However, as the findings migrate from an extreme position towards the middle, the interpretation must be viewed with less certainty. For example, a maximal tapering spanning 3 to 5 centimeters above the sternal angle with a borderline ovoid form and a size only 1.5 times the size of the common carotid artery should be interpreted as a borderline exam. To sum up, here are a few take-home points. Volume of flow through the internal jugular vein is dependent on the incline of the head of the bed. The IJ has a tendency to collapse with decreased flow as the incline of the head of the bed is increased. The internal jugular vein will remain open if the right atrial pressure is elevated and the pressure column rises higher from the right atrium. Next, proper setup is paramount. The patient's bum should be in the crick of the bed. Leave the head in a neutral position. Next, assess breathing effort and other potential contaminants that can impact interpretation of the JVP. In particular, forced expiration can result in significant differences in the height of the column. We should also be cautious in patients who have had surgeries or trauma to the neck or multiple IJ cannulations. Next, assess IJ diameter, form, and position of maximal collapse. Also consider using Valsalva as an additional data point. Next, lower the incline of the head of the bed if the taper is seen at the level of the clavicle. Remember that the anatomy of the internal jugular vein at the level of the clavicle has a tendency to stent the vessel open. Next, adjust the height of the head of the bed to make the taper acute. The position of the JVP is difficult to identify if there is a long, drawn-out taper. Next, layering is not the same as pressure. Layering may be seen if the patient is relatively flat. If the IJ is no bigger than the carotid in the supine position, without the head of the bed at an incline, the appearance of a column is likely not related to pressure and is related to layering. Next, remember that the JVP often underestimates right atrial pressure, especially at higher pressures and a steeper incline. Consider the fact that the distance between the right atrium and the sternal angle generally increases as the incline of the head of the bed increases. Finally, the power of these data points lies at extremes. The references for this talk can be found here.